and make those embers glow. I'm on my way, and I don't skip a beat. I can't help it, I've got happy feet. So good, I do what I want and it's understood. There's no stopping me when I'm doing my thing. I'm doing my thing. I'ma do me. You know what I mean. I'm on fire. I'm feeling glad there's a spark in my soul. Feel my heart go zing. I'm clapping my hands and I'm pulling these strings. No stopping me when I'm doing my thing. I'm doing my thing. I'ma do me. I'ma do me. You know what I mean. You know what I mean. I'm on fire. Yes, I am. I'ma do me. I'ma do me. You know what I mean. You know what I mean.
Christmas time is here, happiness and cheer, fun for all that children call their favorite time of year. Snowflakes in the air, carols everywhere, olden times and ancient rhymes of love and dreams to share. Sleigh bells in the air, beauty everywhere, Yuletide by the fireside and joyful memories there. Christmas time is here, families drawing near. Oh, that we could always see such spirit through the year. Sleigh bells in the air, beauty everywhere, Yuletide by the fireside and joyful memories there. Christmas time is here, families drawing near. All that we could always see such spirit through the year. Smooth like butter, like a criminal undercover. Pop like trouble, breaking into your heart like that. Cool shade stunner, yeah, owe it all to my mother. Hot like summer, yeah, I'm making you sweat like that. Oh, when I look in the mirror, I melt your heart in two. I got the superstar glow, so I step right into my beat. High like the moon, rock with me, baby. Know that I got that heat. Let me show you, 'cause talk is cheap. I step right into my beat. Get it, let it roll, smooth like butter. Pull you in like no other. Don't need no usher to remind me you got it bad. Ain't no other that can sweep you up like a rubber. Straight up, I gotcha, making you fall like that. Oh, when I look in the mirror, I melt your heart in two. I got the superstar glow, so I step right into my beat. High like the moon, rock with me, baby. Know that I got that heat. Let me show you, 'cause talk is cheap. I step right into my beat. Get it, let it roll. Smooth like crochet, you know we don't stop. Hot like ain't no, you'll be like, oh my god. We gon' make you rock and you sing. We gon' make you dance and you say yeah. Hotter, sweeter, cooler, butter. Get it, let it roll. Smooth like butter, like a criminal undercover. Pop like trouble, breaking into your heart like that. Cool shade stunner, yeah, owe it all to my mother. Hot like summer, yeah, I'm making you sweat like that. When you try your best but you don't succeed. When you get what you want but not what you need. When you feel so tired but you can't sleep. Stuck in reverse. And the tears come streaming down your face. When you lose something you can't replace. When you love someone but it goes to waste. Could it be worse? Lights will guide you home and ignite your bones. And I
Hello everyone, this is Dr. Mark Kwan from Bice Institute. I can't believe that this year is almost coming to an end. I must admit, I'm very much looking forward to the year 2022. In the upcoming year, we have set out on incredibly exciting study club sessions for you. 8 very popular topics. As many of you are already familiar with the format, each session is composed of 3 components: a lecture, a live demo surgery, and a post-surgical discussions. We've designed each and every session to be filled with interactive contents to optimize your learning experience. Each live online study club session starts at 6 p.m. Pacific Standard Time. After each session, a live recording replay will be available for the next 5 days for unlimited viewing. This may be particularly useful for those of you who may not be able to attend live sessions due to geographical time differentials. We also wanted to make these events fun and entertaining as well. So there will be giveaway prizes during these sessions. However, prize draws will only happen during the live sessions. So if you want to win some, you better stay up and show up. Some of the topics for 2022. Session 1, sinus elevation using casket versus DENSA drills. Session number 2, soft tissue augmentation using free gingival grafting by Dr. Bernard Jin. Session number 3, implant complication management. Session number 4, guided bone regeneration using novel approach by Dr. Arbor Louis. Session number 5, locator overdenture with focus on digital workflow. Session number 6, third molar extraction by none other than Dr. Neki Jamal. Session number 7, guided versus freehand immediate molar therapy. And lastly, to finish the year end with an exciting topic on socket shield therapy by none other than Dr. Jeff Lee from Toronto, Ontario of Canada. I'm sure you will definitely find some of these sessions, if not all of them, very, very educational and clinically useful. Each session qualifies you for 3 AGD credits. Bice Institute Live Online Study Club is a unique, highly interactive implant educational platform, and we are absolutely certain that you will love each and every one of them. Don't forget to sign up for the early bird registration by January the 1st to receive exclusive Bice souvenir gift set box for the first 20 registrants. So enjoy your holiday season and give yourself a gift of learning. Be safe, be kind, please take care, and we hope to see you soon. Bye.
All right, I think we're live. Almost Happy New Year, everybody. Hope you guys can hear me all right. I wish everybody a wonderful, happy, and healthy holiday that you're having right now. Okay. All right. So today is kind of last minute, isn't it? Right? Last minute. Hope everybody can hear me okay. I haven't got a chance to sound check it yet. Hold on. Yep, our sound is good. I'm a one-man show once again. So today was an interesting a day because all of a sudden I found myself not much to do in the evening, and instead of doing it at 10 o'clock, decided to do it at 9 o'clock. My last one almost killed me. It was like 4 a.m. Started at 2:30 a.m. and finished about 4 a.m. So today I'm in more of a normal time zone, So I hope some of you guys can join. So today is an interesting one because it's like a reaction video. But let me tell a little bit about tonight's intention is during the pandemic, I got a chance to meet online some of the really, really great clinician and educator around the world. It's interesting because these are the people that I would normally not really run into, but because of the pandemic, that kind of forced all of us around the world, kind of get to know one another and start to collaborate during the 2020. And one of the things that I did during that time, during the lockdown of 3 months, I didn't have nothing to do, and I started this lecture series called the Begin Stay Home. Encouraging dentists to connect with one another and share their knowledge without any a reward or no monetary reward. It's just the fact that we have this time and share one another knowledge and learn from each other. And this is a lecture by one of the doctor I've have a profound respect for. His name is Dr. Y.K. Kim. And he did a presentation called Hopeless Does Not Mean Useless. I've listened to it one time at that time, but it was one of those lectures I wanted to listen again because I found so many pearls. Personally, I've learned a lot, not only from a technical perspective, but also from his philosophy. And I think it's something that all implant dentists or just regular dentists can learn from. So, no further ado, let's start the session, okay? All right, let me see right here. Here it is. Okay, let me just go PIP. Okay, all right, so let's start. And as I'm watching, I'm just gonna speak my thoughts. If you guys do have a question, please leave comments and I'll try to address that. And hopefully, I think the lecture is about 40 minutes, 30, 40 minutes, not a long one, but a very educational one for me. So hopefully it'll be same for you. Good morning, ladies and gentlemen. Welcome to another episode of Begin Stay Home mini lecture series. It is episode 12. It is my great honor to host special guest this morning from Philadelphia. I've been a big fan of his work for the past few years. I've come to enjoy and appreciate his meticulous case workups and execution. This man is special. It is rare to come across a fellow clinician who is so well versed in both periodontal surgery and implant prosthetics from both academic and clinical perspective. Thus, when he agreed to be this morning's guest speaker, I was absolutely thrilled. Dr. Kim has been in academics and clinical practice since 1991. He has received his dental degrees from both University of Sao Paulo, Brazil, and from the University of Pennsylvania.
So he's been to dental school twice.
He then further pursued his dental education for another 4 years and received a specialty training in periodontics, dental implantology, and fixed prosthetics from University of Pennsylvania. Dr. Kim is currently a clinical assistant professor of postgraduate periodontics and periodontal prosthesis at the University of Pennsylvania School of Dental Medicine, where he has been a key
He's a dual
member of
major,
faculty since
right?
1994.
His
He has several
perio
article
specialty
publications
and also
and
prosto.
he regularly lectures to dental organizations. When Dr. Kim is not with his caring patients or his students, he enjoys spending quality time with his wife Hyuna and 2 sons, Aaron and Eric. The title is Hopeless Does Not Mean Useless. Let's welcome, from the city of brotherly love, Dr. Yong-Keun Kim.
Hello everyone from the Bite Institute. My name is YK Kim.
He practices his private practice in Philadelphia, but he's also spends a day or two each week teaching a grad Perio and grad Prostho.
And I really appreciate having us join such a prestigious group such as the Bite Institute. And I thank you, Dr. Mark Kwan, for the invitation.
UPenn University, right?
And
Yeah.
I'll be sharing with you, using the opportunity in this limited time frame, a little bit of experience, our humble experience in our practice. And I am located in Philadelphia, just outside of Philadelphia. I do 4-day practice and 1 day spending time at school at University of Pennsylvania School of Dental Medicine. And we've been doing this for past 20-some years. And,
I mean, he doesn't look that old, but he's been practiced for almost 30 years, right?
What we call it old school. And this slide is what I get to share almost every time with colleagues and with the residents at school, get inspired.
And he's very genuine, and he just loves to share his knowledge.
As a colleagues and mentors and students.
But what really impressed me the most is not just his clinical skill, but his philosophy.
Experience and learning from each other. Our practice is a small practice, and material I'll be sharing with you is a material done in private practice, not a school setting. we spend limited time in school, and my practice has to run to provide food on our table. The philosophy of
Because
that
school
is
doesn't
a
pay much, right?
patient-centered,
So he's
growth-driven dentistry.
he
That's what
works
we
at
try
school
to
for passion,
practice.
and he runs a
My
private practice
background
to pay the bill.
is born in South Korea, raised in South America and Brazil, where I graduated from University of São Paulo College of Dentistry, and continued my education here in U.S. in Philadelphia by University of Pennsylvania School of Dental Medicine. And after dental school, we did years of training in Perio department in the program of periodontal prosthesis, and that's what we try to stick with in terms of a philosophy of the practice. So
He has a
patient-centered
tremendous
dentistry
clinical
not
experience in
only
both
include
Perio
constructive
and
dentistry, but
Prostho. It's very
that
rare
secondly
that somebody
applies
will
to
have
preventive
that
dentistry
depth of
also.
knowledge in
So
both
my practice is
disciplines.
general practice, and proudly we say that we highly specialize in general dentistry. And
It's
the
funny,
main
his philosophy is even though he's a
the
dual specialty, he
concept that
considers
we carry
himself as a
on
very high
is the
level general
formula function
dentist.
of masticatory system. The form has to follow the
It's a
function,
come around the
meaning
full
that
circle.
the form of the teeth has to follow the objective of the function. And whatever the technique we utilize for that has to be based on solid foundation, has to have a solid concept. That's the heart of our practice. And today we try to share a little bit of a humble experience we have under the title of hopeless doesn't mean useless.
See, when I first got this title from him, when he, you know, when I first did an invitation, I didn't really know what to expect, right? Hopeless doesn't mean useless, you know. But after listening to his presentation, it really left a lasting impression.
We're going to focus a little bit on a specific area of the technique we utilize based on our concept. And it's amazing what we as a human being can do in terms of a professional field, but not only that, in entertainment and recreational, the human being has an ability that is no other being out there is capable to. And applying that even within our profession, since the implant was introduced by Professor Bernard Mark, so much of a change and advancement has been achieved. And here is a case by Dr. Gonzalez. The size of the defect on anterior maxilla we have, and how much of regeneration of the lost hard tissue he could achieve utilizing a specific technique and material. So here's a case by Dr. D'Ambrosio, not only surgically but even prosthetically. It's fascinating what we as a human being can achieve. And of course, we know as members of the Bite Institute that many of the members and our faculty has shown unbelievable aesthetic outcome utilizing both surgical and prosthetic technique and concept. What I want to focus though today in healthy dentition we have when we have a loss of one or multiple teeth, and we as a dentist we try to restore this, and of course implant today is the one of the main players in restoration and reconstructive dentistry. And if we end up replacing those missing teeth with 1, 2, 3, or 4, or whatever the number of implants, whatever the location we decide to place those implants. And here, just for sake of illustration and discussion, let's place 4 implants in there to replace first bite, and upper arch. And we can do that very successfully and beautifully, as many of us have seen works of our own and of our colleagues, as the case that we just reviewed a couple of minutes ago. The question I have the struggle I have is from the placement of the implant until the insert of the final restoration, which timing could go somewhere from 2-3 months to, depending on amount of reconstruction we need to do, could go 6, 7, 8, 12
Sometimes over a
months.
year, right?
The question is, what do we do in between while we are waiting for the integration of those implants and before we place the restoration? Of course, there are several options. We could nothing, leave the area fully dentless. We could utilize removable procedures such as what we call a flipper. We could use an access appliance, and of course, there's always an option of immediate loading.
Which is
Those
what I do,
implants.
but not many general
Me
dentists
personally,
comfortable
I
doing that,
try
right?
to avoid immediate loading if at all possible. Not because that does not work.
See, this is the thing, right? Me and Dr. Kim we have a great mutual respect of one another immensely. But the way we approach the similar cases, it differs drastically. For me, I live and die by the sword, right? I'm an immediate guy. And because for me, uh, it's worth the risk, right? It's worth the risk. The benefit for me outweighs the risk. But I'm a minority. I understand that. I am a minority, and many of periodontists and prosthodontists and general dentists that I talk to, they're not comfortable with immediate loading at the level that I do, and which I totally understand and respect. But that doesn't mean that our outcome is different, right? And you'll see with his cases that his outcome is incredible. So this is particularly useful because for many doctors who are not comfortable doing immediate loading, but still wants to do comprehensive implant therapy, and he's going to show us how he does that without having to immediate load.
And I do whatever I can to prevent that, unless I have absolutely no option but doing it. And of course, we always have options out there. And today, 2020, in the field of implant dentistry, we get to see cases like this being published
Yeah.
and being posted in social media and being taught by many of opinion leaders in our field. Not necessarily me personally. I'm true fan of this, and periodontics being as my background, I was trained to save the teeth. I was trained to save the hard and soft tissue, and aggressive removal of dentogingival unit and bone is not my method.
I used to do that, right? I mean, like when I was first taught to do a full arch immediate loading, the all-on 4 protocol was removing the alveolar bone and the teeth. It was aggressive alveoloplasty. And he's right, I used to do that. And I used to teach that too, right? It took me over almost 15 years for me to come around. And where I am now, so I'm a zero bone reduction guy, and I do appreciate, his thought process.
Preference. And on that aspect, I'll try to share with you some ideas how we handle patients during that phase of osseointegration that we are awaiting before we can proceed to final prosthetic and ultimately loading those implants that have been integrated. Generally speaking, my waiting time of the implants in upper arch and maxilla is 3 months, mandible 2 months,
Wow.
generally speaking. If we need to add
So like this is interesting, right? Even though he does not do immediate loading, okay? Yeah. Professor Kim doesn't do immediate loading. the way the amount of time that he waits before he actually loads is actually shorter than what I do. I wait about 4 months for upper and about 3 months on the lower, depending on bone quality. But he goes 3 months for the top, 2 months for the bottom. See, for me, I wouldn't be comfortable loading it that early, unless the bone quality is great.
ER procedures, a sinus lift, maybe we go about 4 or 5 months. Most of the time, the most 5 months seem to be enough of a healing time. The question is how our patient will survive and function while we are waiting for those implants to be healed so we can load. And I do my best try to avoid leaving the patient edentulous out of function, and I do my best not to give them a removable appliance if at all possible. I want to have them functioning pretty much as a normal dentition, functional fixed dentition as possible. And that's what we'll be discussing about. So here is a patient where upper right side 5-unit bridge is compromised and the supporting 2 out of 3 supporting teeth are deemed hopeless. And here is the occlusion, how that go. Patient lower arch occlusion is a little less than optimal, but the most posterior second molar is pretty much non-functional at this point. And the treatment plan that we are going to deliver to this patient is we're going to section the existing bridge between the canine and first bite. We're going to maintain that crown on canine as it is without replacing. We'll be extracting those 2 supporting abutment teeth, the molar and the premolar. And the idea is to replace 1 implant on that first molar site where it is edentulous, and placing another one on the first bite. So, and ultimately we'll be delivering 3-unit bridge on 2 implant supported. The question is, once I section that bridge and extract those roots and place those implants, the patient will be pretty much edentulous on 1 arch posterior, and how we are going to manage that. And I don't want to leave the patient edentulous non-functional. So basic idea is utilizing those hopeless teeth as an interim abutment and give the patient a full unit cantilever bridge at the time of or before the placement of the implants in there. And patient will be functioning with that fixed bridge throughout the time while we are waiting for the integration of those implants. Once the implants are integrated, then we do the uncovery, and simultaneously or right after healing of the soft tissue, we are gonna jump that provisional the patient has been waiting to the implant, and having those 2 natural teeth abutment that deemed hopeless is still present. Those 2 abutment will guide the provisional restoration to exact location, so we can connect the temporal cylinders from the implant to the bridge without affecting the position, without affecting the occlusion of the provisional that we had maintained from the time of the surgery to the time of the loading of the implants in there.
So basically what he's doing is he is using those hopeless teeth to maintain the vertical dimension of occlusion, and at the same time during the 3 to 4 months of implant integration, patient has a fixed provisional bridge on those hopeless teeth. So it just has to, those hopeless teeth just has to last for a few months until the implant gets integrated.
Because the hopeless is not useless, these hopeless teeth serve the function of restoring the function while we are waiting for the healing of the implants and the dentition is not present. Obviously, once the implants are connected, now we can extract those hopeless teeth, and we're going to graft the socket, and of course making sure that all the prosthetic components are fitting properly. As we see here, we found out that the temporal center was not fitting properly. I know the faculty from the Bite Institute had reviewed this before, I make sure to eliminate, trim the flare on the base of the temporal cylinder. And here that was not done sufficient enough, which is binding on the bone and prevent the further sealing of that. So those are the details that we need to make sure we address properly. And once the soft tissue has healed around, then we proceed to final as usual. So this way, from the beginning, at the time of the presentation, with very compromised function from the existing bridge, we restored the upper right procedure with the implants without leaving this patient out of function of mastication and not depending on a removable appliance. Same idea can apply to many different scenarios. Here we have a patient where upper arch is compromised, and not only the upper arch, but periodontally with the advanced decay and the mobility, occlusion has collapsed, occlusal plane has compromised. And here what we plan to do is analyzing all the details of that, and discussing treatment plan is not the focus in here, but we'll be restoring this patient, treating this patient with the full upper arch implant supported fixed bridge and the lower posteriors, and we plan to do 7 implants on the upper arch. Many of them are immediate placement at the time of the extraction. And we're going to restore that with the full upper fixed and lower posterior, rehabilitating and reconstructing the occlusion as a whole. So maintaining every one of those teeth that we diagnose as a non-maintainable, we'll go prepare those teeth normal way as if we would restore this as a natural dentition supported. We temporize a proper occlusion and addressing the function. And on the day of the surgery, we are going to select the strategic location where the implants need to go.
Wow. Do you guys see the level of dedication here, right? Commitment. So, Dr. Kim, number one point, the vertical has to be reestablished. There's a lot of these full arch cases, right? There are a lot of times that are overclosed. So they need to increase the vertical. So how he's going to do that before the implant therapy, what he's saying is he's going to do a traditional crown prep, remove all the old failing bridges, and regardless of the hopeless teeth, he's going to prep them like a normal prep, okay? And then he's going to temporize it to a proper vertical dimension of occlusion. And on the surgery day, he's going to take the teeth out selectively where the implant needs to go and use the remaining teeth that was already previously prepped. He's going to make a temporary to suspend that vertical dimension of occlusion, okay? Maintain it till the integration, end of integration stage. That's a lot of work. At least for me, if I were to do that. Because it takes me longer to do each crown prep than to extract and place an implant, right?
In a few of the hopeless teeth, because the hopeless doesn't mean it's useless. And utilizing those hopeless, they will have a fixed provisional at the time of the implant placement. So from the beginning to this point, even after all the implants have been placed, patient is functioning with the fixed restoration. Once the 3-month of integration period has gone, now we remove the provisional, extract the remaining teeth, and retrofitting the existing provisional to the implants that are healed already. And again, just like before, because we have a number of teeth, hopeless teeth, holding the provisional, they serve as a guide for us to position the provisional exactly the same location as we attach the implant cylinders to that provisional.
So what he's saying is that he had a provisional that was held by the hopeless teeth. Now, once the implant's healed up, he's going to use the same provisional and he's going to hollow out where the implants were. I think that was the pontic area. He's hollow it out and he's going to pick up the cylinder using the existing provisional, okay? and then that's going to support the vertical dimension of this provisional. Meantime, where the 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 abutment was for the failing hopeless teeth, now it's going to be retrofill to become the pontic of the version 2 of the bridge. I think that's what he's trying to say. I think, yeah, if I understand correctly.
Patient has been functioning with the fixed provisional that meets all the requirement of a form and function, including the aesthetic. From before the implant surgery, through the integration period, and after the healing of that, and this provisional that had been supported by hopeless teeth now serve as a blueprint for the fabrication of a death.
This is important because if somebody were to tell me, Dr. Kwon, what is the most biggest challenge of a full mouth reconstruction? It's not the surgery, right? It's not even the immediate loading for me. It is establishing the correct video and maintaining that correct video throughout the surgical and the prosthetic phase. And this technique that Dr. Kim is utilizing to maintain the video, but also aesthetic and also the phonetics and everything is quite brilliant.
Restoration. So the final restoration, which comes from provisional supported by hopeless teeth, basically is the same restoration, little better refined with a little better looking material, little stronger material. But as we see, successfully restore the full approach on 7 implants without extracting all the existing teeth that we diagnose as a hopeless, without putting this patient having a single day edentulous, or depending on any removable appliance. And here is a before and after, and that treatment time we complete within about 7-month time. Of course, we pay the price of the work because it's an additional work we need to do to maintain, to deliver the provisional and to maintain the provisional. But our opinion is that time is well spent, well invested for the well-being of the patient. Having waited about 3 months, spending about 3 months of integration time between first and second stage of the implants, waiting roughly about 6 to 8 weeks after extracting those remaining hopeless teeth and grafting the socket. That takes us roughly about 5 months of a healing time they will be waiting, but very effectively, efficiently, we can rehabilitate the patient.
Yeah, Anna, this is a very good question. I'm going to pause it here. Was the implant placement guided or free-handed? Very accurate to be able to keep the final 1 unit. I believe he did this free-handed. There was no mention of a guided. I mean, I could be wrong, but the good thing about doing this method is you don't necessarily need guide because you already have the adjacent, those hopeless teeth gives you good reference point for you to be able to freehand it, you know, in that arch form and in the angulation. So unless the implant position has to drastically vary, differentiate a lot from initial dentition position, I think his a provisional design and also the existing adjacent roots, you know, serve that reference point quite well.
Without again depending on removable appliance. Natural teeth were made to be fixed, and we try to maintain our patients in conditions like that. However, in cases like this,
this is tough.
Advanced to a point that these teeth are pretty much sitting on the air.
I mean, this is, come on, right? This is pretty severe. That's a class 3 mobility, right? I mean, how would you keep these hopeless teeth?
Basically, soft tissue holding this, as you see, extent of bone loss in there. Patient is a male patient, early 40, and state of his condition is obviously very, very compromised. And I wouldn't be surprised if many of us approach this case with this kind of relatively invasive, and it's a method not necessarily that I
Yeah,
agree
that's
with.
aggressive. That's
But for
aggressive.
whatever reason, um, the social media makes it.
See, I used to do that, right? Use a saw, chisel, reduce at least 7 millimeter from CEJ to the basal bone. I never felt comfortable. You know why? Because the reality is that if it was my mouth, or if my parents' mouth, or my wife's mouth, I don't think I have the heart to do it, right? And that was the biggest thing that bothered me, right? The whole concept of reducing these precious bone just so that we have a space for the FP3 prosthetics. Okay.
Appear as if this is kind of standard of care in 2020 implant dentistry. Despite the fact that patient dentition was very, very compromised, analyzing every aspect of the occlusion and function, on the laboratory we do a diagnostic therapy, and we transfer that to the mouth also. Same idea, keeping number of those hopeless teeth, and we are going to deliver fixed provisional full upper and full lower. Doesn't need to be ideal, but serves interim function, and it gives us the guidance toward, it serves the blueprint toward the final reconstruction that we'll be designing and delivering. Within this kind of okay provisional, there is all the information that we need for the final reconstruction has been built into it. So same idea on maintaining this hopeless teeth in selective and strategically decided and identified sites. We'll go place
So he
the
does all
implants,
the preliminary
and while
wax
the
up,
implants
digital
are
wax up, and
healing,
everything
the
beforehand,
provisional continue to work.
so that
Both
his
full upper and
interim
lower
provisional on the hopeless
provisionals are
teeth
maintained.
is going to
Implants
be
are placed, and
pretty
we do
much more or
necessary
less what the
modification of the
final is
hard and
going
soft tissue.
to be,
Minimum
right?
necessary
Minimize
to
the guessing game.
rehabilitate the form and function. And here is a radiograph of those barely secured natural teeth supporting the provisional, both upper and lower, while the definitive implants are healing under the provisional without being loaded. Because hopeless teeth are not useless teeth. And already Thomas Edison taught us before that just because something doesn't do what we plan it to do doesn't mean it's useless. So natural teeth which were meant to function to deliver the need of mastication and phonetic and aesthetic and so, not because they fail to do that, we shouldn't deem them to be useless. And here is the case pre-op, and during follow-up of a 9-year follow-up, we are getting into close to 10 years now on this patient. As you see the dramatic change of soft tissue morphology and how it relates to dental anatomy there. Of course, it's far from being identified as an optimal and ideal result. But comparing to pre-op, where we are coming from on this severely compromised dentition and massive amount of bone loss, what we achieved there.
I think Anna said a very good question. Is this a single final unit, wraparound one unit? I'm not 100% sure. These are all a bunch of PAs. It might be, but if it is a one wraparound unit, I mean, that takes some serious skill, right? Because I don't think I could have done it because I like my final prosthetic screw retained. It would be for me, it would be impossible to have everything seated to a fixture level. It'd be very difficult to do a screw retain. So possibly they are segmented. If they're not segmented, I'm guessing they're all one unit, then it will be custom abutment so that you can customize the abutment so that you can get the draw properly. But even then, that's hard to do, right? That's hard to do. Kudos.
I believe is a satisfactory. And
Actually, if you look at right here, there is a segmentation here. I think there's a segmentation here. But I'm not so sure about the top, okay?
maintaining very well without aggressively removing the soft and hard tissue that we um, know is so precious. So once the extractions, if you, one can imagine on the clinical condition of that, if we had extracted all these teeth because they were hopeless from day one and had given upper lower full denture, interim full denture, or had we extract them all with the technology we have doing manufacturing computer generated bone reduction guide, and had we placed the implants at the time of the extraction of this teeth or after, um, I doubt it that we would have achieved the outcome that we did.
Mm.
Extraction of the teeth can be done at any time, can be done today, can be done tomorrow, it can be done next month. We as a clinicians should be no need of rushing into extracting teeth, and not only the teeth but how has been performed very commonly today, resection of the precious soft and hard tissue, not necessarily in my personal opinion for the well-being of patients, but many times I see that as more of as a convenience for us as a clinicians. And again, the radiograph. But what if for a case like this, is it really feasible for us to try to maintain this? Wouldn't it be much easier, much more time effective and convenient if we go just extract this tip, put the bone reduction guide, and do O12 and O13, O1X, and what?
I mean, you gotta admit, that's pretty extreme, right? That's pretty extreme. Like even for me, this will be a stage case.
That may be. That obviously is an option. Um, in our practice, we try to avoid that. Treating every one of these hopeless teeth in very useful and productive way, we can achieve an outcome as what we have. Again, not saying that the result we achieved is ideal, and it's far from being ideal.
No, he's being modest.
But
That's as good as it gets, in my opinion, from a condition that started.
Of a zirconia in there with yards of a pink to replace the resective procedure that we perform on these patients, this type of patients. And if it wasn't for the hopeless teeth, there would be no way they would have preserved this much of an attachment apparatus in there. So precious, soft and hard tissue there, achieving a result like this. There would be no way. But is there a limitation? How about cases like this, where we did the compromise of the dentition to a point that we have really absolutely no idea where to start with this, But utilizing the same concept of a periodontal prosthesis, which is nothing more than general dentistry, by the way. That's why I say that, I proudly say that I specialize in general dentistry. Utilizing all these hopeless.
Do you like that? He's a dual specialist, periodontics and prosto. But when I was asking what his discipline is, he specialized in general dentistry. Because his philosophy is that it doesn't matter what discipline that we practice, we have to respect the occlusion and the biology and at the end, we're here to restore function in a most minimally invasive approach possible, right? I love it.
We can achieve result like this
That's
one.
incredible.
And this is all implant supported, just like a previous case, applying the same idea, same technique of setting up proper landmark relationship on the model and transferring to the mouth and utilizing the hopeless teeth to preserve the precious soft and hard tissue volume that we already have lost a lot. For sure, extraction and loading is not an extraction and resection of the compromised crest of bone is really not the way we practice. But what if we don't have enough of hopeless teeth? Then we need to find ideas and use the creativity. Thomas Edison said all his work is a 1% of inspiration and 99% of perspiration. So here we are using a combination of a hopeless tooth, one of the hopeless tooth which was the best condition there on one side, and utilizing two mini implant. This is a 2.5 millimeter
temporary
mini
implants.
We utilize as a transitional.
Professor Sohn does that quite often.
Immediately placed and immediately loaded to support the full lower arch, while permanent implants, the definitive implants, are healing under the provisional without the loading. And once the implants are ready, we'll go remove those transitional implants and final reconstruction is done. Not only for the hopeless teeth, but hopeless implants concept applies same way. This case represented with the full upper implants that has been failing with the major bone loss on pretty much every one of them to the apex. As you see, we are going to keep three of those hopeless implants to support the interim provisional, which has been bar reinforced, and the permanent implants heal under the provisional. It is a panoramic and of a low quality that has been quite of a distortion.
Oh, wow.
As you see the provisional arch in there. But the point is, during the integration of those implant, patient is to function with the fixed restoration, utilizing the hopeless implants. And because hopeless are not useless, hopeless teeth are not useless, hopeless implants are not useless, and of course, this technique and this method is always an option. One of my mentors had mentioned before, there is your way of doing it and there is a right way of doing it. And I still stick to that criticism my mentor gave me. And I know there are many different ways of doing it. And as per Einstein, great spirits have always encountered violent opposition from mediocre minds. And Thomas Edison, my hero again, there is always a better way of doing it. There is always better way. Better than the best that we think it is. He says, go ahead and find it. And that's why I use the title of my Facebook page as Learning is a Never-Ending Journey. Utilizing each other's help, each other's idea, inspiring each other, we try to find the goal and objective to make our profession better. And I hope some of the ideas shared with members of Bite Institute was a little bit of a helpful on this difficult time that we are going through. And hope we'll all be well, be safe and healthy. And I'm looking forward to one day I can meet all the members face to face for us to discuss ideas and concepts and to inspire each other. With that, I thank you very, very much for your help, and I hope to see you all soon. Thanks and bye-bye.
Oh wow. So I hope you guys enjoyed it. Even though it's my second time listening to Dr. Kim's, YK Kim's lecture, um, not only I learn a lot from his technique and his treatment planning and all that, but more importantly, um, clinician like Dr. Kim is very rare, right? He inspires me, and it's his philosophy that I learned the most out of, right? Okay. Um, and even though he does things different than the way I do, our concept and our philosophy is similar in that uh, we're now both trying to achieve the same or similar outcome, patient-focused, biology-focused outcome, but just taking a different approach. He trying to avoid immediate loading as much as possible because he want to minimize the risk of implant failure. So he goes about trying to keep those hopeless teeth as long as possible and use them to establish the uh, a final outcome-based design utilizing provisional fixed provisional bridge, and then by time of 3 to 4 months of osseointegration, and basically use that blueprint to transition over to the final. I think that's brilliant. I do the same thing. Only difference is that I immediately load on the implant that I place, and I give a most ideal transitional bridge. I do it my way because I'm comfortable and I have the lap support to do that. But not many of you have the in-house lap support like I have. And not many of you can deal with implant failure if were to happen the way I do it. Because in our clinic, we're equipped to deal with implant failure. If it does to happen, we can counter that with a prosthesis, another new prosthesis. We can mill it out, but not many of you guys can do that, right? So like I find this presentation very relevant. Okay, very very relevant, especially if you're a general dentist. Okay, um, and if you do see a case, and if there is a remaining hopeless teeth, and you're able to do a crown prep, okay, most of you guys can crown prep way better than I can, and use those to do a fixed provisional and buy time until those implant and the bone graft heals up. It is a very feasible approach to provide your patient a comprehensive, complex, even though it may be complex, it is within the reach if you break it down like Dr. YK Kim did. Okay, so I think it's a very good approach. It's really something for you guys to think about, and and a lot of people ask me, Dr. Kwon, when can you teach me FP1 digital workflow? The reality is that I can teach it, but not many of you guys can do it because there's no commercial lab that can support my concept at this present time, right? We're just too far ahead in the curve of digital workflow. But Dr. YK Kim's approach, we can do that, right? Most of you can do that. Who's a general dentist can definitely take this approach and do it. So I once again thank Dr. YK Kim for really opening up our eyes. Okay, just like Anna said. And I think it needs to be reminded that we don't need a fancy equipment and fancy digital. Now, not all of you guys need to have a fancy 5 people full-time working lab technician in your office to have an outcome like mine. Okay, my way is not the only way to do it, right? There is a way, and Dr. Kim has proven that, and he's been doing this for almost 2 decades before all the digital era came in, right? Of course, not everybody, is a great clinician like Dr. YK Kim. He's being humble. He's a periodontist and prosto. I mean, I cannot take that lightly, right? But with the right approach, and we don't have to do a resective ivioplasty, put those implant when the computer tells you to put it, and convert the denture into these cases, right? Because ultimately, his philosophy, same as mine, is to preserve and conserve it. That's what dentistry is all about, right? Be conservative as possible, minimally traumatic as possible, um, save biology, and promote healing, right? And I think it was a great lecture. He always inspires me. Amazing clinician. There's another lecture that I've invited him in the past a late night coffee show, and that was another eye-opening session as well. Hope you guys enjoyed it. If any question, you can leave a comment here. I will tag Dr. YK Kim and he can answer a lot of our questions. I'll leave this video up until the holiday season's up. Enjoy it. Send the link to your friends and colleagues who you feel that's going to benefit from today's presentation as well. Okay. Hope you guys have a wonderful night and thanks for joining my private study club. Okay. You guys take care. See you soon. Bye-bye.